Because we don't see PEDS patients every day.
One's interested. Okay, so now we are recording live, and there are people from various programs who are joining us live right now as it's streaming. So let's start with our first one here. And Nicole, you want to start us out?
Did you say me? I'm sorry.
I did. Go ahead.
So you've got papillomatosis
You did.
and round parakeratosis. Church spires, I think I saw some hemorrhage in the horn as well.
Yeah, very good.
And then you've definitely got some sort of viral change. So there's granular cytoplasmic inclusions, and they look more red than purple to me from this power.
And
So
we're probably on acral skin.
So I'm thinking myrmecial.
So myrmecial wart. So the key to myrmecial wart is like any wart, there's papillomatosis, vertical columns of parakeratosis that is distinctly round, hemorrhage commonly in the stratum corneum. The stratum corneum is either compact or coarse basket weave. And in a myrmecial wart, there are viral inclusions that are distinctly red, and it is palmoplantar. So, very good. Let's start with, let's get something that's a little different.
So you have some acanthosis and squamous, maybe a little atypia since we're in the viral chapter.
So you very cleverly and correctly pointed out that even though it looks like a seb on architecture, there are parts of the body, like down there in the privates, where things can look like a seb but not really be a seb. And the hint is typically in the corneum. A seborrheic keratosis has a corneum that is shredded wheat lamellar, and if you look at the corneum here, not only is it compact, but the parakeratosis often is not round, is not flat, but is distinctly round. And we did a study, and there was one other study that showed that that is predictive of which ones will hybridize on in situ hybridization for HPV. So if they have a wart corneum, it's a wart. And so the corneum is where the seborrheic keratosis-like lesion in the groin tips its hand and tells you it's actually HPV. So compact or basket weave corneum, round parakeratosis is the hint that it is actually a wart. This, by comparison, would be a more typical condyloma. Broadly acanthotic. Again, the stratum corneum is exactly the same as what we saw in the one that looked like a seborrheic keratosis. Compact or coarse basket weave, distinctly round parakeratosis, but coilocytes are present. Unlike cervix, where a coilocyte must be a black, pycnotic, shriveled, crenated nucleus, in skin, coilocytes are typically vacuolated, but the nucleus is large, gray, and vesicular. So it differs from a pap smear coilocyte, where it's a crenated black pycnotic cell. In skin, they're typically large, gray, vesicular, with a visible nucleolus. Okay. Okay, so we have a lot of edema, a lot of inflammation, and then, Dan, what do you see here?
There's an ulcer and some neutrophil debris. I'd like to take a look at the endothelium since we're in the viral chapter.
So,
make sure we don't have any CMV.
Endothelium, you would look for cytomegalic cytomegalovirus change. Tell me about the dead epidermis. It's actually a little better. Let's get the focus again here so that those on monitor are always in focus. Okay. So, how do you think the epidermis died? Are they holding together, or are they round and separated?
They're a bit round, separated-ish. Could be a herpes.
Yeah, so suggests that they died via ballooning degeneration, where they are now big, circular, dead blobs of red, as opposed to confluent or net-like blobs of red. These died a ballooning degeneration death, which suggests herpetic change. So the fact that the epidermis, although dead, is dead in a recognizable pattern of big, round, red blobs suggests that it's herpetic. So even if you don't see active herpetic change, the ballooning degeneration is a helpful clue.
I don't know if we were.
However you want to do it. Is good.
So there's a warty stratum corneum here.
So warty corneum, and in this case, it is compact but has little holes in it, forming a coarse basket weave. Looks like someone has taken a tiny little punch and taken tiny little round holes out of a red stratum corneum. Okay.
So I would think that this is mostly wart. It's got the alveoli coelicites there.
Absolutely. And where do you think we are, this highly vascular tissue?
We're on the probably leg or some,
Or
genitalia area.
yeah. And then what has happened in this wart?
We're looking like there's some atypia in there as well. So there's like some mycotic figures I don't really like too much that you're pointing out with a nice arrow. So it may be undergoing some squamous changes in there as well.
Exactly. So this is invasive squamous cell carcinoma arising in the setting of condyloma. If it's a high-grade invasive carcinoma like this, what HPV types most commonly?
6, 11, 6.
So for the high grade, more likely 16, 18, 31, 33. What you're alluding to is verrucous carcinoma, which is more commonly 6 and 11. So common HPV types give you verrucous carcinoma when it's invasive, whereas the high-grade carcinoma like we're seeing here is usually the types that we give cervical carcinoma as well. So-called high-risk HPV types. Okay, David.
Papillomatous, epidermis, there's like alternating, like ortho, probably some para in there.
So what do you think it would have looked like clinically? With the papillomatosis, hyperkeratosis?
Like a seb, probably, or like a
or
condyloma seb.
something warty,
Warty.
right? It would have been a warty lesion, warty surface. Papillomatosis, hyperkeratosis. So
hypergranulosis, cordyceps.
And they're very large and glassy.
Yeah, so probably getting towards like full thickness atypia, and like bonoid papulosis.
Tell me about these clusters of cells. Let's make sure we get it in the screen so everyone can see. So in the follicle, tell me about these clusters of nuclei.
So could that potentially be a multinucleated giant cell?
They're multinucleated giant cell, and
So more
they
like-
all have a peripheral basophilic rim of cytoplasm with a red center in the nucleus.
Is that more HSV
So it's
VZV.
more herpetic change, and
Eggshell.
you correctly said it could be either HSV or zoster. Do you know any setting in which a patient would have multiple verrucous lesions that would show herpetic change in the follicles?
HIV or immunosuppression.
Exactly. So
Verrucous
you
zoster.
just diagnosed the HIV infection in this patient with verrucous zoster. So verrucous changes in a herpetic infection is almost always zoster, almost 100% zoster virus, and it's severe immunosuppression, 99% of the time HIV, occasionally a patient who has instead of HIV has is on cancer chemotherapy or some other form of immunosuppression. The lesions show glassy verrucous atypia, so they may be misdiagnosed as squamous cell carcinoma. They may be misdiagnosed as warts. The key is noting the multinucleation, nuclear molding, and margination of chromatin, so the 3 M's of a herpetic infection. Even when you look back at the verrucous areas, you can see the multinucleation and nuclear molding. Where the nuclei become small and dark, that's where it's usually easiest to see the margination of chromatin, where there's a peripheral basophilic shell of blue and the center is red. So verrucous zoster, essentially diagnostic of HIV infection.
So I think it's me. These look like molluscum bodies.
They look like
And
molluscum bodies.
Patterson bodies.
Exactly. So this one, very straightforward, makes a good coffee table picture. Probably never appear on an exam because it's far too easy, right? So, and that doesn't count as your turn.
You do too much, Robbie.
I think that goes without saying. So this cyst was removed from a patient.
Right.
And tell me about the cyst lining.
So, looks like it has some almost like blue granular cytoplasm within the cells.
Tell me about the corneum within the cyst. Is it lamellar, or does it is it compact red, punched full of round holes?
Coarse, punched out, full of radicals. I mean, I would think like a verrucous cyst, maybe.
Like a verrucous cyst. So verrucous cysts are papillomavirus-induced cysts. They start on acral sites in the acrosyringium and in other sites in a hair follicle, become a cystic lesion. This one has coilocytic atypia and some atypical mitoses. When they have a high-risk type of HPV, they go on to become cystic squamous cell carcinoma. So many cystic squames arose as cystic papillomas or verrucous cysts. Okay. This is someone who came back from the Caribbean on vacation and had a black lesion next to the toenail, and their family doctor said, boy, I'm worried about melanoma, and they punched out that little black lesion next to the great toenail. What did they just punch out?
Some kind of worm.
Some kind of something alive, right?
Mm-hmm.
The gut is filled with blood, so it's something that was blood-sucking. It has striated muscle. You can call for a consult. Someone, what embeds next to your toenail after you've been walking on the Caribbean beaches? Tunga penetrans. So it's not a worm, it's a flea, a gravid flea that is originally native to Africa and now common on beaches as far north as Myrtle Beach. Now, so it is present on South Carolina beaches as well. What?
Is the eco button pressed in?
Oh, that
Seems a little dark.
Let's see.
Isn't the line all the way up?
So our well,
Polarizer's going up.
polarizer's out. Let's see.
It's not that bad, but I just didn't know if
That's not on preset. So it was on eco. I've taken it off there. It doesn't seem to be. Is that changing the light for you guys?
Yeah,
Okay.
it's fine.
A little
Seems-
dim.
Just seems a little dim.
I'll figure it out after.
Oh, you know what? Neutral density filter. That's what. There you go. Look at that. Okay.
Right.
Now are we burning retinas or are we? Okay. Tell me when we're comfortable.
Good.
Good there?
Mm-hmm.
Okay. So if that ever happens, the neutral density filters are down here.
Okay.
And someone just bumped it or moved the keyboard and knocked it. And so let's see what we got. This is probably worth doing this one. Let's see.
Thin shave, very robust inflammation superficially with some crusting.
Yeah, so crust and inflammation, and I'm going to just walk you through. When you look across, you got normal sebaceous gland,
Mm-hmm.
and then you've got a necrotic red sebaceous gland. Necrosis of sebaceous gland is a hint for what diagnosis?
Maybe EBV?
Or more commonly, anything, fellows?
HSC.
Yeah,
pathetic.
herpes. So necrosis of the sebaceous gland, eosinophilic necrosis of sebaceous gland suggests a herpetic folliculitis. And then if you look here, we're just starting to see a little margination of chromatin. Let's get that in the field there. So you can see there, I think we are there. So a little margination of chromatin, peripheral basophilic eggshell of chromatin, paler in the center, multinucleation, molding of adjacent keratinocytes, diagnostic of herpetic change. That's maybe a little too red. Let's skip that. Let's do. Okay, this is a good one. So,
It looks like there's some acanthosis and some cloacytic change. Certainly, looks HPV induced. Doesn't quite look like EDV, but
So
there's
what's-
also that cookie cutter, change in the stratum corneum. So I would favor maybe a flat wart or some sort
exactly. Sort of broad and flat, so verruca plana, flat wart. And you commented on EDV change. What would EDV change look like?
It's kind of that blue granular material of polyribosomes.
Correct. Okay. So, skin,
Yep. Muscle.
and because these are your favorite, this is
Oh,
what's in the
worm.
fat.
So this worm does not have a gut.
This worm does not have a gut.
This worm has a tegument with subtegmental cells.
Yeah.
Smooth
Smooth muscle,
muscle. I don't
basophilic
think-
calcareous bodies.
Yeah, so I would be at Sparganum.
Yeah, so it's a flat worm, not a round worm. In practice, if you got that far, you're doing pretty well.
No, I'm saying worm. There's a worm.
And so the flatworms include flukes, so trematodes and cestodes. The cestodes are basically tapeworms, and the trematodes are flukes. This one is sparganum, and one of the things that can help is you get a little double layer of smooth muscle above those subtegmental cells, which you can see easily with a trichrome stain. But that's if you got as far as worm, you're doing pretty well.
So it looks like, yep, diarrhea.
So why diarrhea?
It's a bachelor.
That is very specific diagnosis, sir. How do you know it's diarrhea?
Yeah, the thick muscle.
So thick muscularis, and tell me about the host response.
It's pretty, it's like an abscess.
Yeah, so a huge suppurative host response, which is a clue that this is not something adapted to living in humans. The human is an accidental host, and you're getting a vigorous host response. There is a uterus, which you can see right there. Most worms have a bifid uterus, so you see two tubes, but it is non-gravid. Right? It's a solitary, convoluted worm with a very thick muscularis, and the analogy the residents like is onchocerciasis. They're married, so they got no muscle, and the diarrhea are bachelors, so they're all pumped up and muscular, and they look good, but they're lonely. So. Okay.
So it's kind of looks like a botfly.
Yeah, exactly. So you see the little CD. So we're seeing a thick chitinous wall, and you're seeing these little short brown angulated hairs or CD that anchor the organism into the flesh. And so that tells you it's a botfly. Myiasis, correct.
So again, we've got a warty sternocorium,
Yep.
alternating ortho and parakeratosis. I can't tell from this slide, but it looks very much like the verrucous HSV we saw earlier.
Because
so
it is the verrucous HSV we saw earlier, and your short-term memory is intact. But this is a very important diagnosis. You don't want to miss it. You see the viral cytopathic change, the peripheral basophilic chromatin. It's important because you still see these patients. No one knows they have HIV. They haven't been tested. They show up with these verrucous cutaneous lesions, and the biopsy tells you not only herpetic, but that the person is HIV. So, very important diagnosis to make.
I guess that'd be me. So we have it's like a worm with, is that the bifid uterus perhaps? With like a thin muscular layer?
So, a lot of them will have that. This worm, the best thing is it's short and fat, right? So this is a very stubby, fat worm.
Mm-hmm.
And
So it's the other onchocerciasis, perhaps?
Well, onchocerciasis is usually narrow and convoluted. This is a big fat thing that, like roto-rooter, is just burrowing its way forward through the tissue, and you have migrating urticarial lesions starting several weeks after eating sushi or ceviche.
Is it schistosome?
So,
Or
probably.
Charlois, or no?
So, anyway, what do you get from eating the raw fish that just sort of migrates slowly through your? Well, it's a
No, it's not. That's a different.
yeah. Gnathostoma is the one. So, gnathostomiasis, which is a burrowing worm. It's in the fish. The pickled fish in ceviche. The worm likes it just as much as you do. It doesn't hurt the worm, and so it's still entirely viable.
It's a night crawler.
What?
Nothing. Someone had to replace James a little bit.
Okay.
I said it looked like a night crawler. I'm sorry.
A night crawler, just like a.
A night crawler. I get it. That was good.
I'll be quiet. Go back to your corner.
No need. That was funny. Uterus, okay. Okay, go ahead.
So looking at the cornea, it looks like maybe some pigtails in the most superficial.
So you have, in the corneum, you have little twists and pigtails, which tells you that this patient has
Scabies.
scabies. And if you look at the top and you look at what is being recruited, what kind of cells, you have these reniform nuclei with ample cytoplasm, eccentric nucleus. How do you think those might stain?
CD or stain for Langerhans.
Yeah, CD1A positive for
Langerhans.
Langerhans. And there are plenty of scabies patients who get misdiagnosed as Langerhans cell histiocytosis. Kids, they get put on chemo for a misdiagnosis. And then in the older people, remember, it can mimic pemphigoid. And IF can be positive. So scabies can be bullous with positive IF, and bully filled with eosinophils because it's an arthropod, so really mimicking pemphigoid in an older population, and in kids it can mimic Langerhans cell histiocytosis. Absolutely.
Looks like a pretty exuberant reaction in the dermis with the serum crust.
What's that?
Is that a hair follicle?
Yeah, or erector pili. What's that?
Is that some HPV change?
So, what kind of structure?
So is it necrosis?
Necrosis
of
of
the sebaceous gland?
necrosis of the sebaceous gland, which suggests what?
HPV.
You're thinking the right thing, and the wrong words are coming out of your mouth. Exactly. So you are absolutely correct. So at scan, you see erector pili, you see intact sebaceous unit, and then you see eosinophilic necrosis of the sebaceous unit. So already you know it's herpetic. And then you're just going to look at the follicle, and you see some ballooning degeneration. But it's a scan diagnosis. Eosinophilic necrosis of the sebaceous gland is a herpetic folliculitis. Not necessarily immunosuppressed for that population. So, pretty broad.
Looks like it's looking relatively normal at scan. A little bit of superficial inflammation.
A little superficial inflammation, otherwise relatively normal.
Are we looking for filariasis?
Well, we're looking for something, right? Let's see if it will cooperate. There we go. See that little guy there?
I feel like that's a blood vessel. Like scan.
So that little twist, what are we looking at probably?
Like microfilary.
Microfilaria, exactly. So now you had said, you mentioned filariasis. Do you think this is filariasis, or so what would be the difference between a filarial worm and a microfilarial worm?
Size.
Size, you got it! So, this is about 1/100th the size of what a filarial worm would look like. So, elephantiasis, you've got a big worm lodged in lymphatic. Microfilaria are called that because they are micro, right? So they are much smaller than the filarial worms. And then, as long as you get to, this is microfilaria of some sort, then the next question becomes, does the patient need treatment? Do we have to prevent blindness? And you can enlist help to get someone to identify it. Because in much of the world, You have streptocirrhosis, which is completely benign. It makes you itch, but it will never get in your eyes. Whereas onchocerciasis causes blindness. So, but you don't have to make that call. You just have to identify the microfilaria.
Because that's so easy.
Because
That's so easy.
well, actually, though, what would happen is when I was at AFIP as a resident, we would get specimens from South America and Africa once a month that was sent in for a pigmented melanocytic lesion, but all through the lymphatics you have these microfilaria. And so the question is, well, and you would see undiagnosed leprosy, you'd see all sorts of things in the background. And when you'd see the microfilaria, the question is, in addition to telling them whether this is or isn't melanoma, you got to tell them whether to treat or not to treat the microfilaria. So,
I mean,
just finding them.
If they were in the lymphatics, that would be one thing, but I'm like
Oh yeah,
the one
It's out
hanging
there.
around in the dirt.
although you'll see where you just happen upon them in tissue. It happens.
I thought you were getting at leopard skin. That's what I said.
Oh, leopard skin. Got it. Okay, I get it. So leopard skin is the chronic eczematous change from filarial dermatitis. Whereas, so leopard skin is what you get if you are a local who has it chronically. If you come as a visitor, so you're not local, and you come and you get this horrible rip-roaring dermatitis that darkens and hyperpigments, that's what's called SOWDA, SOWDA, and that is a rip-roaring reaction to a microfilarial worm. When you saw that, you saw there was hardly any inflammation around it. If you see a microfilarial worm, tons of inflammation around it, that's someone who came over as a missionary or something. They're not local to the area, and they're getting an exuberant dermatitis from the filarial worm. That's SOWDA. Okay.
This is like a onchosarcoma.
So how do you know that it's onchosarcoma?
Well, it's a convoluted ball of kind of like a paired worm with a bifid uterus with maybe some microfilaria.
Yeah, so
there.
she's pregnant, and he's
Not.
flabby and no muscle.
Yeah, there's no muscle.
Yeah, so he's got no muscle, she's pregnant, they're married, right? So that's onchocerciasis as opposed to the studly worms that are dirofilaria that, get nothing for their trouble, but they look good.
So there's definitely atypia in here.
There is definitely atypia.
And so I would ask where it came from.
So this
Site.
comes from a vulva.
So my differential histologically is squamous in situ versus like a bonoid papulosis, but I can't tell the difference just on the slide.
Well, exactly. So you have to look at the patient clinically.
What does the patient look like clinically?
The patient has multiple sessile brownish red papules.
Then I would be more on the bonoid papulosis.
But I lied. The patient actually has an expanding velvety plaque.
Then she probably has squamous in situ.
So what have we learned?
She could have either.
Well,
That
we
you
have-
lie.
That
That
I
you
lie.
lie.
That's the first thing that we learned, right? And the second thing is that clinical pathologic correlation. So the term bonoid papulosis was coined at the AFIP at a time where women were getting radical vulvectomy for little papules that the clinicians were saying were more like warts. And so to prevent radical vulvectomy, which was inappropriate therapy, the term bonoid papulosis was coined. At the time, they honestly believed that this was a wart-simulating carcinoma in situ. Now we know it's an HPV type that's giving rise to the earliest phase of carcinoma in situ, but radical vulvectomy would be very inappropriate therapy, and something like a Miquimod would be much kinder, gentler, more appropriate. So the diagnosis still has value. There was also at that time on Pap smears, histo or cytotechs were taught to ignore HPV change because it was a simulant of malignancy. No one realized at the time that it was the precursor to malignancy.
It looks kind of wedge-shaped. But there you may have some eggshell.
So you have peripheral basophilic eggshell-like chromatin in multinucleated cells with nuclear molding. What are you leading towards? So you're saying that that is herpetic change, but is that the whole story? What else do you see here?
Those are some inclusions. Where
So
are those dead reds?
I see a red rim around the nucleus. I see cells that are larger, dyskeratotic, and acantholytic. So why is there a little focus of acantholytic dyskeratosis and also herpetic change? And this is someone who now is head to foot, kind of blisters and sores.
Sure.
So anyone?
And Darius in there.
So Darius with eczema herpeticum. Exactly. So who gets eczema herpeticum? Kids with eczema, but also kids with Darius. People who have a defective corneum, defective cutaneous barrier. So important diagnosis because they become head to foot herpetic lesions. It's most commonly on a background of atopic eczema, but the second most common diagnosis would be background of Darius disease. And it often they have known Darius, especially in the adults. They have known Darius, and then their Darius is just flaring and getting worse and worse and worse. And it's not until someone makes a biopsy or does a biopsy that the diagnosis of superimposed eczema herpeticum is made.
Just 'cause you can't see it with all the acantholysis lesions.
Commonly, clinically, it may just look like horrible explosion of their Darius. So the diagnosis can be very helpful. But fortunately, you were there, you saved the day, you made the diagnosis.
After they have one eczema herpeticum, do you just put them on like chronic suppression? Then are they usually?
That's a good point. So, so Christina, you just made the diagnosis of eczema herpeticum. You have this patient who's head to foot flare of their Darius. You just put them on antiviral, and their skin looks better than it has in the last 40 years of their life. What are you going to do now? I would put them on lifetime suppression.
Oh.
That's typically what we do. If the patient doesn't want to do it or can't afford it, then the other thing that you can do is just have them episodically treat. So any flare of their disease becomes presumed herpes.
Do you do that with atopics as well, or more? You're talking more about Darius patients.
So the atopics, we will sometimes do that as well. It's easier to see when they have eczema herpeticum. It's going to look like eczema herpeticum. The problem with the Darius patients is you never know if it's their disease flaring or if it's the eczema herpeticum back.
Is there a clue when, like, there's no history of vaccination, how to tell it apart from
From eczema
chickenpox in a child?
vaccinatum or, oh, I see. So chickenpox tends to be tighter, smaller vesicles. you have a little more of a vasculitic response, but not as much as zoster. But you can do the fluorescent. Well, you can do PCR or you can do DFA, direct fluorescent antibody, and you can do it on your biopsy. You can do it on the tissue. So that often, leads to the diagnosis there.
So I'm not seeing clear-cut epi.
And that's partly because we are not skin.
It was a little unfair in this conference.
So, we're actually at the edge of an unhappy liver.
Okay.
And in this unhappy liver, we have a cystic, partially calcified cystic lesion in this liver. And that's one area, but let's see if we can find a better one. This is something you could see in skin. This particular one happens to be hanging out in the liver. I don't want to waste too much time on it, but let's see. You usually get a big "oh wow" when we find it. We have all the calcified areas. Oh, that would be a shame if that's the best one we had. What's that one at the edge? They are circular rings of hooks, basically. So, that would tell you this is a hydatid cyst.
Is that the one transmitted from dogs?
The hydatid cyst dogs will
Yes, it's a sheep or a dog.
carry it, but it's the sheep as well
Yeah.
that have them. So in Australia, it is illegal to sell an apple once it's fallen off the tree and hit the ground because of risk of hydatid. So only fruit that was picked from the tree up in the air is legal for sale in Australia because of the risk of hydatid disease in a sheep herding
It's gotta be tough
country.
to enforce.
Yeah.
What?
That's gotta be tough to enforce.
Which is why they have the world's highest incidence of hydatid.
That's where the 5-second rule came from.
It takes more than 5 seconds for a guy to take a serious.
Do they have to extend the 5-second rule?
Yeah,
Shorten
exactly.
it.
Shorten the 5-second rule. Yeah, exactly. Our family, we are firm practitioners of the 5-second rule, but not in Australia.
Dr. Elston,
Yes.
can you request approval, take a picture?
Oh, of
this?
course.
All right, thank you.
Absolutely.
So this.
Everybody
Oh,
smile.
I
Hand
never
it
remember
down.
to be studying or not.
Thank you.
Okay.
So this is a mammillated surface.
Yeah, mammillated surface, and what do you see here?
I see some warty change again.
Yeah, and tell me about your corneum.
It's got those punched out little areas in it.
Yep,
So I feel like I've gotten condyloma or genital warts the entire
exactly.
time. But
That is exactly right.
I'm getting it.
The expert.
You're just stamping out disease right and left.
And an extra modifier now.
How many were there? Actually, the expert.
I am. Well, I mean, that's what it is.
There you go.
Nice. All right, so we have some epi that's generating probably more like ballooning generation versus reticular, and then lots of multinucleated giant cells.
And anything
eggshell.
about the nuclei that's helpful?
Yeah, there's nuclear molding and eggshell kind of calcification,
Suggesting?
herpetic.
suggesting herpetic change. Why is there such a neutrophilic response here? And it looks like there are a couple of vessels that are blown away.
Yeah, it's going to be zoster with like more.
So with the heavy neutrophilic response and vasculitis, more likely zoster rather than simplex.
Is this the Bifida Uterus? Or?
So there's a Bifida Uterus. It's a gravid worm.
Come on, Shane got this in like 2 seconds. He like looked at it and said it.
Oh, it's it's not dilophoreus.
So it's not dirophilaria. The
It's,
muscle's too
Onchocercoma.
So does onchocerciasis get a rip-roaring immune response like that?
Not usually.
So this is, do you know any other kind of filaria-producing worm? In this person with very swollen legs?
Oh, elephantiasis.
Yeah, so that's just, so you can see the little microfilarial larva in the gut, but the filarial worm itself is the big guy there. So that's Wucheria bancrofti, which is your usual elephantiasis.
This
Okay,
looks like
I want
they
you
were
to
walking
tell
on
me
the
the
beach.
whole story.
They were walking on the beach,
They were
potentially
walking
in
on
Myrtle
the-
Beach, moving north south.
And this is?
Tungiasis.
You are correct. That is tungiasis. And you will see them. I mean, in New York, once a year we had a tungiasis biopsy that would come through.
Crazy.
And it's what, you either recognize it or you don't recognize it. Let's see what else we got here.
Very small. Almost just looks like the top of like some molluscum.
That's exactly what it is. So, that's a potentially testable molluscum where you've got you've got lots of red herrings, lots of distractors, and then you got a few Henderson-Patterson bodies, and it's just a question of, do you recognize them? The other thing that's important is for the fellows. This change here, that's what not quite Henderson-Patterson looks like. So that is fair and I think testable for a fellow, is something that is not quite, because any idiot can recognize a Henderson-Patterson body. It takes a special idiot to recognize the changes that aren't quite there yet.
They're just like the intranuclear inclusions forming, and then that'll turn.
That's exactly right.
So that's not like
So-
multinucleated.
No, it's not. It's a single nucleus, and that becomes this. But it's recognizable, and it's it's just like anything else. It's just recognizing the. Let's see if we can get that into focus. Recognizing that pattern as what is about to be a Henderson-Patterson body. Let's see. This we may or may not be able to see it. It's probably worth trying. It's something kind of
Liver?
This is liver, absolutely. So you get the liver again. And within this liver, you've got these things. So it's got these group nuclei, and it has a chitinous rim, and it's got a fairly thick wall, and you might even see a lateral spine.
So it's just a
Yeah, and which one?
Mansoni.
You are correct. With the lateral spine and the thick wall, that would be schistosoma mansonii. So That's absolutely correct. So that's schistosomes. Mansonii tends to go to the liver. Hematobium tends to go to the bladder. So, and let's see, we have time just for a couple more. Let's see if we can grab. Trying to get high yield here.
Oh,
So,
I'll
but
describe
the-
this piece first.
Okay.
So, you have a superficial and deep perivascular and interstitial mixed inflammatory
With many,
EOs, and it's kind of wedge-shaped
so you would think.
arthropod.
Exactly. And why don't we just say bite?
Because not all arthropods bite.
Yeah, exactly. It could be a bite, it could be a sting, it could be an infestation, and what is it in this case?
That's scabes.
That's a scabe. Okay. So, we say arthropod reaction because you don't know if it was a bite, a sting, or an infestation. And in this case, it's scabies.
With a salt, please.
We call it yes, that's how we diagnose it as an arthropod assault reaction.
Yeah.
Don't think it's
It was what type of one?
Yeah. It's definitely a worm, maybe a very large worm, like
So-
a flat.
Yeah, like a very large flatworm. So first off, it has no gut, right? It has calcareous body. It has smooth muscle. It's much larger than what we saw before. And it seems to have constrictions. So it looks, have you seen a Christmas cactus and what that looks like? Okay, so your assignment is to
Not West
Google
Virginia.
Christmas cactus and look at what that looks like, because the segments of the leaves of the Christmas cactus look exactly like this in outline. So this is tapeworm. Yeah. So, your typical Tania pork or beef tapeworm. Here we go. Let's go a little higher. See how the leaves, how they form those segments that fit together. That's exactly what the tapeworm looks like. And you see the constrictions there where it forms those individual cell segments. Each of those, they're friable and they break off, and then each of those can germinate into another.
How did you get that slide, Dr. Elston?
Which one?
The tapeworm. Like, who said you had tapeworm on a slide?
Oh, people send me. Everyone knows I
They'll
like.
send us worms in jars. You laugh, but they do.
They do. They come into the lab.
They send us worms in jars all the time
Yeah.
because they want to know what it is.
Oh my goodness, okay, got it.
So we get worms, we get ticks, we get bed bugs, we get. It's the perfect gift.
Dr. Elston.
So if you ever want to know what to get me for the holidays, right? It's a worm. Okay,
Get your Christmas cactus.
that'll work too.
Is it my turn? Okay.
Yep.
Scabies.
Scabies. Exactly. It's fine just to say it when you recognize it.
You ready to graduate?
Like, if I can get that and that, and then, yeah, you could be dermatologist.
Alright, some very elongated echinthyotic epidermis.
Where do you think you are?
Probably acral, potentially. Actually, up there. I mean, could be. This could be like hypertrophic mucosa. Because
Although
is this in
there's a big
slips?
granular
Yeah,
layer,
there
so it probably is acral.
you go.
Acral skin.
So a lot of cloacidic, kind of like some EDV change, the blue foamy cytoplasm granular, something HPV related.
Yeah, so HPV, and these things are not cytoplasm like in EDV. They're just huge nuclei.
Bless you.
So that is what's called coilocytic atypia. And this coilocytic atypia, even though that's about a 40-pound nucleus, it's meaningless. That if the atypia is restricted to the coilocytes, it's not a premalignant change. So you look at the surrounding skin and there's no atypia at all. So the high-risk HPV types, you get atypia of the surrounding skin. The bizarre extreme coilocytic atypia is absolutely meaningless. So, that's just a wart when you have that kind of coilocytic.
Do you have any EDV examples, Doctor?
Well, we do. I mean, you had them in the earlier session, too. Let's see, do we have another one handy there?
We did not. There were
Oh, you
there
did?
was none in the.
I thought maybe one was in there.
You're kidding. We need to put one in there. Okay. There was one, but it was kind of bleached. So, what we can do, we'll send, because clinic is starting, we'll pull a beautiful one, take a photo mic, send it around.
Okay.
Okay. So you'll have it for comparison. Okay, that's it.
Thank you.
Thank you.
And enjoy your morning, enjoy Charleston, and we will see you for sign out.
You're at the VA in the afternoon.
Yeah.
Your winter field